So let's talk about hormones, just from a sort of big picture perspective.
Sure.
What are the most important things that people should know about hormonal health, and how you would recommend that people monitor that? Because I think that's something that we don't, I mean, people know a lot about T clinics or hormone therapy for menopause, or at least they think they do. They know what they've heard.
Yeah.
But I think not always talked about is like for individuals, when is it important to start paying attention to hormones?
Sure.
And what should we be looking for and thinking about?
I think I'm going to stick with women to start, because
absolutely.
I do a lot more
Actually, I think
women's
we
health.
should do that, because too often on YouTube, the conversation focuses around men's hormones. So we're going to talk about female hormonal health.
Yeah.
Okay.
And I think we should I think I'm best to talk about it, hormonal health in general, from when we talk about perimenopause on.
Okay.
Right?
Got it.
Fertility and PMS and PCOS and all that, that's kind of another thing. But hormone replacement therapy and hormone decline in women as they age. So perimenopause is that phase where usually I kind of tack it on age 35 on, and not quite menopausal yet. So still cycling, but having decline in fertility, decline in hormone production.
And I think most people would be surprised by 35 as the point that you start thinking about this.
I usually say that, so that could be 20 years. I mean, someone might go into menopause till 55. And so it's this spectrum of decline in hormone production and function and all of those things, which can be for some women fairly silent, for other women very, troublesome as far as symptomatically.
Right.
And so I really kind of talk about, okay, which hormones are we really talking about? There's, the three main sex hormones we talk about as estrogen, progesterone, and testosterone. And typically when you see that trajectory, testosterone for women usually actually starts to slowly decline, probably in their 30s. And then you start to see progesterone being the second one to start happening in that, 35 on. And then really estrogen is declining a bit, but zigzagging quite a bit, but usually just dropping off the cliff right at menopause when menstruation stops or is stopping, And so it depends on the patient, but perimenopause, it doesn't mean we have to give them hormones. I think, can we do things to get as much out of those ovaries for as long as possible? There's going to be a point at which we just can't do it, right? And there's different herbal formulas and different dietary approaches sometimes that can actually really help with hormonal health. And there's a few different herbs that can be supportive. And so we sometimes start there. And then when it becomes pretty apparent that there's some real symptoms going on here, then we'll look at replacing hormones.
Yeah. Let me ask you one question, which is around. You said it can be silent in some women, or it's all based on whether they experience symptoms, right? And the question is, what are your thoughts on whether or not hormone therapy should be used or considered in people who are not experiencing symptoms, or they don't know that they're experiencing symptoms?
To talk about.
Okay, great.
I talk to patients about this. There's two. So in menopause, I'm going to talk more menopause at this point. I kind of group it into two things. There's symptom management, and then there's risk reduction.
Yeah.
And I think this is where those women who have very little symptoms are done the most disservice, because no one's saying to them, well, you don't really have any symptoms, you don't really think about this, or they are not thinking anything about hormones because they don't really have any symptoms, and that's all they're thinking about.
Okay.
Right.
Yeah.
But there are some women, and maybe they're the lucky ones, have these severe menopausal symptoms where
That's funny, because I'm sure they don't feel like they're the lucky ones, but it's an interesting perspective.
Medically, in a way.
Because they know
because
that something's going on.
I mean, it's such a quality of life issue. They can't think, they can't sleep, they're whatever it may be, they're reaching out for help. And hopefully they are treated with hormone replacement therapy.
Right.
I mean, there's other things that sometimes are given, antidepressants and some of these other things, that can also be effective for some of these symptoms. But, hormones are probably the best thing to give in that case. And so great. Their symptoms are managed. They feel so much better and wonderful. And here's all the things that are happening at all the silent stuff.
Right.
They're slowing the development of heart disease. They're protecting their bones. they're probably delaying the onset of Alzheimer's or dementia.
Yep.
And reducing risk of colon cancer, extending their lifespan by some studies up to 3 or 4 years, preventing all-cause mortality, and I tell them that's even car wrecks, by maybe close to 40% when you look at meta-analysis.
Yeah.
How could it be car wrecks? Why would we think that? Because the brain works better, the reflexes are better, all of those things.
Right.
Those are all silent. So then here's the woman who's like, doctor's saying to them, well, no, you don't really have that many symptoms. You don't need anything. What about all of this? What about, preventing osteoporosis, which is a big, big deal.
Right. And again, most people aren't looking for osteoporosis in their 40s and 50s, right? So you aren't going to see it until it's too late if you're not looking for it.
Right. Yeah. For me, it's never too late.
Yeah.
I mean,
sorry, maybe I shouldn't have said too late.
I love
you're going to see it at the optimal time to have the optimal
to be preventive.
Outcomes.
To prevent things, because then you see, maybe it's 10 years out from menopause, and now they're saying, oh, this is too late to start anything. Yeah. Well, not really. I mean, there's really not a lot of data that really shows it's harmful to start later. It's just that the ball is rolled down the hill a little bit further, and some of these things have already started to happen.
Right.
So you can still benefit in some ways, but things have already happened.
Yeah.
So
your view is that
yeah.
even in women who are, like you said, 10 years post-menopause, there's often value to starting.
There may be some value for them. They may actually have, some improvement in some different symptoms, and I do love working with osteoporosis and osteopenia because we can improve bone density.
Yeah, right. Which is good for people to know.
Right. And there's really three things there. There's the ingredients, all your nutritional ingredients for bone health. There's the stimulus. You really need to stress those bones. Right. And then there's the hormones that
and
put
by
it all
stress
together.
The bones, you mean resistance training.
Resistance training. Yeah, resistance training. Yeah. So even when I see a woman who's maybe not been on hormones and it's beyond that 10-year window, and they're saying they shouldn't start hormones, but I don't really believe that's true. Yet they have bone health issues, and we really need all of that stuff. We'll reach for that because we can support bone.
Yeah. And I mean, I think bone obviously is super important.
Yeah.
Interested to know if you agree with my perception here, which is also that the lean mass piece is super important for obviously for metabolic health. And that's something a lot of people don't appreciate. They think, if you're overweight and you have a lot of fat, that's bad for metabolic health. But I think probably just as bad as being under-muscled. And that if your hormonal status is suboptimal, it's going to be harder to build and maintain lean mass, which is a problem for both men and women.
Yes.
I think women, again, it's kind of silent. It's not as appreciated that muscle mass, and we're not talking about like being a bodybuilder, but having a reasonable amount of muscle mass is really important for metabolic health in women as they're
That's
getting
why people
older.
get frail. You see, they're like these these older people, they're just so little. Like, how they get so little?
Yeah.
They've lost a bunch of muscle mass.
And the hormones are critically important for that. So
absolutely. Yeah.
So if I understood correctly, again, I mean, your perspective is that, about age 35, women should start thinking about this?
About thinking about, okay, not necessarily doing anything about it. I mean, unless, because they're probably pretty good on hormone levels about that time, but that's when things are going to start to happen. And maybe they do have changes to their menstrual cycles, changes to symptoms, changes to sleep, and all of those things. And then at that point, during the perimenopausal phase, in my mind, that's a little bit more about symptom management to a certain extent. Although testosterone, if it's a big deal there, then I will
about
put testosterone. I probably will start earlier, especially if there's some issues with that seem to be testosterone related in women.
And what would those be?
Dramatic loss in libido, fatigue, mood, difficulty with building muscle, and all of those things. Yep. So if we see those and we test levels and they look pretty low, then we'll look at, replacing.
And so what are the things that are most important? Like if somebody's thinking about this, what are the things that are most important to get tested? So testosterone, estrogen, FSH. What about SHBG?
I don't always test SHGB because I'm looking at testosterone free and total.
Okay, so you're measuring right. So again,
so
just
I'm
for people we're using a lot of acronyms here, but
okay. So sex hormone binding globulin.
Right.
So usually I think about that. You think about that in the context typically with testosterone, both men and women.
This is a protein that will bind testosterone and estrogen, I believe.
Yeah. Oh yeah. And some thyroid too.
Right. And so it binds multiple hormones, but we think about it with testosterone because most of the total testosterone is going to be bound.
Right.
And so you measure, this is important because a lot of times if you go to your primary care doc and you say, I'd like to have you measure testosterone, they'll just do total testosterone, which really tells you not much.
It tells you how much you have, but it doesn't tell how much you have access to.
Right.
Right.
In terms of function. So you need to know free testosterone, but sometimes people will measure SHBG.
And then you can calculate out. I mean, there's a little bit of another protein that binds it too, but it's bulk, so you can get, and then you get these free androgen index or, I just look at free and total.
So the key is you want to have both total and free, and there's a couple different ways to get
how much you're making, because that's obviously how much is being produced, and then how much do you really have access to do the job of the testosterone? And there's various things that can affect that. So for instance, if a woman has been on birth control pills, that will actually affect this protein and make their testosterone less available to them.
It'll affect SHBG levels. Yeah. So when you take, because you're taking hormones, your body's going to respond by increasing the binding globulin.
Right.
But if you're not taking testosterone, your free testosterone is going to go down as you have more of the binding protein, or if you're not taking enough testosterone.
Right. Yeah. And in some cases, we've seen that having a history of oral contraceptive use may permanently elevate that sex hormone binding globulin.
Yeah.
And so they're always behind the 8 ball. Even if they have normal testosterone levels, they may have very little access to that testosterone, and then they are having symptoms of lower testosterone.
Right.
So you have to push beyond that. That we were just saying the same thing.
Absolutely. Yeah. No, I mean, I think it's this is super important because my perception is this is not widely appreciated among the general public. And there are a lot of women who take birth control, who are on birth control for many, many years.
Yep.
And some proportion of them, and it's probably a fairly significant proportion, are going to have some elevation of SHBG, which is going to lead to a decrease in testosterone availability. Now, do all of them need to take testosterone? Probably not, but some of them probably do.
Yeah. And sometimes, if they're using the birth control pills for that purpose, like in a case of PCOS or something like that, they want that effect.
Right. So it's going to be dependent on the situation for sure.
But I mean, it's, and not every woman has that amount of elevation and, all of that. So it's real individual.
So that's the importance of measuring and paying attention to symptoms, right? So, so you can get blood tests to measure these things. So like for somebody who's now listening to this and is like, oh man, I should take a look at this. What would you recommend that not everybody can come see you. I know you're very busy. You don't have an infinite number of clients who you can take on. What would you recommend what's the conversation look like with their primary care doc?
It depends on what the doc is going to do. I find it amazing that some doctors say, I don't believe in this. I'm not sure what their religion of medicine is. But
one piece of advice would be maybe find a different primary care doc if you can.
Find a different doc.
Okay.
But yeah, I mean, I think they can just say, hey, I'd like to have my hormones tested, and I'd like to have just to have them tested. I don't know if their doctor will do that for them. Hopefully they will. It's not terribly expensive to do those tests.
Right.
And I don't think you need a huge array of hormones. I think you can look at FSH to get a general sense
that's follicle stimulating hormone.
Right. And that will start to go up as you're going to menopause, although it can fluctuate quite a bit early in menopause or as you're going into menopause, but it can give you a sense. You can look at estrogen levels, although those do fluctuate throughout the month if you're cycling.
Right.
So it can be a little difficult to interpret depending on timing. And then you're looking at free and total testosterone. I think you can look at those things and get a sense of where things are. And then you have to put those together with symptoms.
Right.
And understand, okay, just because your labs don't show something frankly out of range, and here's another thing, normal does not mean optimal.
Right. Absolutely.
So, might it make sense to give it a try just to see? Because there's one thing we cannot test, and this is what I talk about with patients with hormones all the time, or at least there's not an easy way to test. Maybe there is a test. how sensitive is that patient's receptors to that hormone.
Right.
And this is where side effects come in. One dose for one person may be too much of a dose for another person.
Yeah.
So that's then where the art of it comes in and deciding on dosing.
So that spurs a few questions. So let's stick with testosterone for now, although I know there are other hormones that are important, clearly.
Yeah, I know. I love testosterone.
So you said maybe give it a try. One question is, how long does it take before you feel confident that you can actually evaluate that it is or isn't in the range that you're looking for? So are we talking like right away somebody takes testosterone the next day, like, oh my God, I feel better? Are we talking months, or does it vary?
As far as how they respond to the hormone and how they feel, usually when we're adding a hormone, someone's going to feel that pretty quickly within the first couple of weeks.
Okay.
Whether it's a side effect or whether they feel a lot better.
Yeah.
Now, those other things that we're looking at is like muscle mass and all those things.
Sure,
that's going to take time, but actually how someone feels, improvement in libido and things like that can be pretty quick.
Can happen pretty quick.
Oh, yeah, that can be pretty quick.
Interesting.
So can side effects.
Yeah, what are the side effects so what are people going to be concerned about, and what should they be concerned about? Those may or may not actually be the same thing.
With testosterone in women?
Yeah.
Classic. What would you think? Facial hair, acne.
Yeah.
Hair loss, maybe. So, and what I say to my patients is, first of all, we're not giving you male level doses. So we're not going to be growing a beard or, these sort of things. However, I say, when you were at your peak levels, which is late 20s, early 30s, when your androgens were probably at their peak, which by the way was about 10 times more than any estrogen they ever made. And they had some issues with facial hair or, just genetically, and they had to do maybe, waxing or something like that. I can probably say, look, you're probably genetically sensitive at the hair follicle to testosterone. So we may be more likely to see a little bit of, really, it's more peach fuzz, things like that. We're not talking coarse beard hair, stuff like that. So I say we might be able to predict that could be you, but maybe not.
Mm-hmm.
Same thing with acne. Adult acne, okay, we know there's more sensitivity to the androgens. So those are both cosmetic things. And what if someone feels fantastic, but we're struggling with a little bit of, okay, so then we try to manage that. Can we do a dose adjustment, or do we have to manage some of these cosmetic things? Right. So those are the top two. When you read the package insert, you'll see lowering of the voice. That usually is happening in transgender dosing.
Okay. Which I'm assuming is much higher.
Oh my gosh, yes. I mean, way high. We're trying to get to male levels,
right?
We're
talking 100-fold?
Yes. Yeah, about 100-fold. And so I'd say it because I have to address it, because it's going to be, you didn't tell me this and I read it. And but I say, it's probably not, I don't see it.
Right.
However, if you were a professional vocalist, we're going to tread lightly, because professional vocalists can notice the tiniest little thing in their voice. So we'll tread lightly and watch carefully. Reversible if you stop, So it's not permanent unless you're on these really high doses for a long time. And then we sometimes see hair loss. So female pattern hair loss is driven by the same thing that drives male pattern baldness. So the genetics involved in that.
Right.
And that is a metabolite of testosterone called DHT, miniaturizes the hair follicle and eventually falls out. So if you genetically already have some thinning hair, like female pattern hair loss, and we give more ingredients to make more DHT, maybe that's going to happen. There's some things we can do to maybe slow that down. I mean, there are things. There's drugs, and then there's things like saw palmetto, which kind of does that in a softer way. It's similar mechanism of action. That's one thing. So if we start saying, hey, the ponytail's getting skinnier, I'm seeing more hair in the hairbrush, okay, we have probably driven that, and now we're going to do something to manage that. So that's one. Some women, it's very uncommon, but I'm like, the hair loss that I like is kind of the sudden hair loss. Not like your hair all falls out, but it's like we know that your hairs are all in these different phases of their life cycle. There's hairs that are in the growth phase, there's hairs that are in a resting phase, and there's hairs that are in a shedding phase. That's why we all lose about maybe 50 to 100 hairs a day. Everybody's shedding hair all the time.
Right.
So I don't know what this is, but there are some women that will start testosterone, not very many, and they have this sudden bit of hair loss, and then it stops. It's the one I like to see because I know it's going to stop.
Right.
And and I feel like what might be happening is because testosterone causes hair to grow. It actually is, it causes hair growth, maybe in places you don't want it, but it can cause hair to grow on your head too. And so is it that you're stimulating this hair growth, and everybody that was about to jump off the cliff kind of just went to the cliff all at once and jumped off, and you see the sudden hair loss? That's my suspicion of what's happening. But usually if it's going to be hair loss, it's probably going to be that female pattern hair loss that you're going to have to do something about. The other one is enlargement of the clitoris. So that, once again, typically you're going to see that with high doses or transgender dosing. However, what happens is in women, the clitoris size will get smaller with age and with loss of hormones.
Right.
So are they seeing restoration to younger, just how it was when they were younger that they didn't recognize? So that's how we have to kind of determine, are we really seeing that or not? You get more blood flow to the genitals. So sometimes initially there's this kind of puffy feeling, but it's more about just restoration, not that we're changing structure.
Right.
So,
and I mean, sometimes these things get called side effects because they aren't the intended outcome.
Right?
Right, exactly.
Effects.
But if some of this is restoration to the way the system was functioning when the hormone was at an optimal level, that's not necessarily a bad thing. It's just not exactly the specific
Is it
indication.
Unwanted? Is it
that's
unwanted?
A different,
right?
Yeah, exactly. Different between unwanted and side effect.
I do have some patients who do not want a libido increase. They're, maybe older women that don't have a partner, they're not interested, they don't want that, and they say that right out. I'm like, okay, so we are kind of careful with that. They just don't want that, so we have to be careful with that piece for them.
Yeah. And then, I mean, even though you and I know this is not something that happens, there's probably some women, I would guess, are concerned that they're going to get too muscular when they take testosterone.
Yeah. Once again, were they too muscular when their testosterone was at its peak levels in their 20s or 30s?
Right. And I think one of the challenges is most women, like I sort of wish I knew what my hormonal levels were when I was in my 20s, but you never get it measured, so you don't know, right? So so I think, the message is you're almost certainly way below where you were in your 20s, and so think about it as we're kind of restoring back to that level.
Yeah. Yeah, exactly.
So are there any significant concerns beyond what we've just talked about with testosterone that you have come across or that you think about? Or is that pretty much what you see at the levels we're talking about?
Pretty much it. Yeah, I mean, that's pretty much it. We don't see it. Obviously.
Cancer is something people have heard about. So
with testosterone?
Yes. I mean, they've heard about it, right? So the question is, since you just said you're not worried about it, I'm guessing that you're not worried about it. And I think,
are you thinking more breast cancer?
Yeah. And I think it's worth just addressing because people have heard about it. I personally know that the literature does not support this.
Right.
And yet it is a common misperception that's out there. Do you have people ask about that when you're talking about hormone? And again, with hormone replacement therapy with women, there's the whole Women's Health Initiative thing too, which we'll get into.
And I mean, that's settled into the public consciousness still.
Yes.
So I've been, working with hormone replacement therapy for many years. So I've been swimming upstream for a long time. And I have these conversations with patients and I'm like, okay, here's the story. And they're like, oh, great. Okay, I want to do the hormones. We get them on the hormones, and then they're like, they feel fantastic. They're talking to their friends. They even may talk to their doctor, and they're like, oh my God, what are you doing? You're going to kill yourself. Yeah. And then they come back in, and we have to have the whole conversation over again because they get scared.
Right. Let's have the conversation right now. Pretend I'm coming to you so that everybody listening can hear this conversation once, and they can come back to it as needed. So if I come to you and we're talking about hormone replacement therapy,
and the concern
and I'm
of
like,
breast
what about
cancer?
cancer?
Breast cancer is the number one thing.
I heard there was this big study and that hormone replacement therapy causes cancer.
Or they don't even know about the study. There's like, I've heard it causes breast cancer.
Right.
So I say, well, that's not true. That's right. I say, okay, yes.
Yes,
unfortunately,
you've heard that, and
yes. And that's, it's interesting because this comes out of a study that was done, way back in 97, stopped in 2002, which was misreported. It was misinterpreted and then misreported in the media, and the media really took hold of it, and so it's really stayed in the public consciousness. And really say, hey, here's what happened in that study, as far as I understand it. So it's called the Women's Health Initiative study. It was, I think $1 billion study. I don't think they'll ever do a study that big again. And they had an arm of the study, and they were looking at women on hormone replacement therapy, and they were trying to figure out what the benefits of this were. And what ended up happening is they started seeing some cardiovascular stuff and increased incidence of breast cancer. So they stopped the study just under 5 years. And that's then what got into the media, and wow, everybody stops hormone replacement therapy. There's some estimates saying that some women may have had premature deaths by being taken off of hormones during that phase where everybody was scared of this and being pulled off of hormones. So that's another conversation. But here's what they saw. So there was a group of women in that study that were on estrogen replacement therapy, and everybody can argue whether or not it was horse estrogen or whatever, but it was estrogen. And they were put on another drug. This drug was called Provera. And that group in the study had this increase in incidence of breast cancer.
And what was the other drug for?
To protect their uterus. So the reason they did that is because if you just give a woman estrogen and just keep giving her estrogen, you are increasing her risk of uterine cancer by causing that uterine lining to thicken up in a way. I mean, annoying, they'll probably start bleeding, but even more concerningly, that could turn into cancer. So they use a drug that's kind of like progesterone, called Provera. It's called progestin, and that's a big brake pedal on the uterine lining, and you're preventing that. So there you go. Those patients had this uptick.
And how big was the uptick?
Not clinically significant, or not statistically significant.
Great.
But they reported it anyway.
Yeah.
And they stopped the study.
Yeah.
So
tiny to the point where it didn't even meet the statistical test for the trial.
But you don't really do that, but they stopped it anyway. Okay. So here's all these other women that were on estrogen only. They had all had hysterectomies, so they didn't need to look at this other drug. Lower incidence of breast cancer on estrogen only. Not statistically significant. They couldn't report that it reduced cancer incidence, but it certainly did increase it. So we know estrogen doesn't increase cancer risk.
Breast cancer
risk, right? But what I do
might reduce it.
Maybe. Yeah. I mean, I think that the European Journal of Breast Health in 2022 published a study on hormone replacement. I think it was estrogen and testosterone, or maybe kind of a mix. I think it was a 9-year study. I think they saw a reduced incidence of breast cancer in that study. So there's some newer things that might actually show lower incidence. That's kind of, looking similar to, maybe even better than the Women's Health Initiative study. So I say, okay, so we know that it doesn't cause breast cancer. But I say, but many breast cancers will have hormone receptors on them. So if you are on hormones and you do develop cancer, you're likely going to have to stop those hormones to treat that cancer, because those hormones could act as fuel. It wouldn't trigger it, but it could act as fuel to help to make it grow. So, and then maybe after you're definitively treated, look at going on hormones again. So that's what I say. Now, even in the Women's Health Initiative, I think 16 years later, they looked back, and this is what I say. And actually, so I'll stop that for a minute and go back, and I say, but if you were on hormones, if you're on hormones and you develop breast cancer, you may be better off. You may be easier to treat. And this is what they saw 16 years later. And I think there's another study that might mimic this too. They looked back at the women who had been in the Women's Health Initiative study, and they sorted them for the women who had later gone on to get breast cancer. So they're looking at those women that were in the study. And then they looked at just the ones who had gotten breast cancer. And they said, okay, what are we looking at? The women who had been on hormones or stayed on hormones were 60 and had later gotten breast cancer, were 63% less likely to have died from their breast cancer than the never users.
A less aggressive, presumably, type of breast cancer, or
it brings up another question. Why is that? I mean, yes, they were easier to treat, or okay, was it because of the hormones, or was it because they had better lifestyle? When they were on hormones, they felt better. They were seeing the doctor more frequently. But I think there was another study done on high-risk patients. This one's a little more murky, so I may not be quoting it properly. And they did women with high risk for breast cancer, the no hormones. The hormone group did have more incidence of breast cancer, easier to treat than the no hormones that end up getting breast cancer. So once again, there's something potentially there.
Yeah.
So that's what I tell them about the cancer thing. Now, is there something to adding this progestin?
Right. Did that cause the potential non-statistically significant increase in breast cancer?
Maybe. And this is when you see these studies that fry my brain when they say progesterone may increase risk of breast cancer, because there are a lot of studies that say that, and it's not progesterone. It's progestin, which is a progesterone analog. So they say it in the abstract, and then you read the studies like it wasn't progesterone, it was progestin.
Right.
So Provera is an analog of progesterone. So I call it a drug with a progesterone-like effect.
Right.
So it can hit a progesterone receptor and give those effects of progesterone common in your birth control pills and some other progestins that are used for women. What we know about progestins, interestingly, is they do bind to a progesterone receptor, but they also bind to an androgen receptor. And there is some data that shows that testosterone can be breast protective. So there's some studies by Rebecca Glazer. I don't know if you're familiar with her. She's a breast cancer surgeon and researcher who's published quite a bit of data, not a lot, but some nice data on testosterone reducing risk of recurrence in breast cancer patients, maybe testosterone reducing incidence of breast cancer. She's actually treated breast cancer with testosterone and had published data on that.
Interesting.
So I don't know if you're familiar with her work, but a lot of that's quoted when we talk about testosterone and breast health. So if you're going to block the androgen receptor, when you also are hitting a progesterone receptor, are you affecting something called BCL2, which is a protein in breast cancer, and you're not able to modulate that with androgens? So maybe
there's a plausible mechanism why this particular molecule.
Maybe there is something to progestin. So that's kind of the
and what is done, because if I understood you correctly, this second drug, progestin, was added to prevent or reduce the potential risk of uterine cancer. What is done today?
Progesterone.
Okay, so it's the difference between the synthetic versus the real thing.
And progesterone attaches to the progesterone receptor, not any other
receptor. Doesn't have
this
androgen receptor off-target effect.
Exactly, which might be why there's an issue there.
Yeah. Okay.
Yeah.
Okay, great.
So I say, no, we're not going to be causing or increasing your risk of breast cancer. Even patients say, well, I have a family history or I'm kind of fearless when it comes to that. I'm like, no, we can do this. And you just make sure we do our screenings and all that, understanding,
Right. And I mean, I know it's not a compelling argument for people, and you don't even need to make it because you just explained that there is no evidence that it increases breast cancer and it might actually reduce it.
Right.
But let's just say, even if it is the case that small effect was real, it was a small effect. And if you think about all of the other benefits that far outweigh that small effect that's not even real.
Yes. I mean, a lot of women die as a result of an osteoporotic fracture.
Yeah.
I think it's pretty close to the number of women who die each year of breast cancer.
Right. And that's not just the small increase that isn't even real. That's the total number of breast cancer deaths.
Right. That we didn't cause with hormone replacement therapy. Right. And so, but the drama around cancer and obviously it's a very scary disease.
Yeah.
But when, way more women die of heart disease.
Yeah.
Right. And we know that women who go into menopause earlier than age 45, when they lose all that estrogen early and they're not replacing it, have a dramatically increased risk of heart disease.
Right.
So we're and blood vessels love estrogen, and so if we can replace that estrogen early enough, we're slowing it. And you see that comparing men to women as far as where heart disease starts to go up age-wise. And if you add hormones, women never really parallel men. Everybody goes up with age.
Sure.
You just slow it so much.
Yeah. Right.
And that's what you're more likely to die from is heart disease.
Right. And I mean, you keep going on the list, cognitive decline and all the other things that are that increase in risk when your hormones are not functioning the way that they're supposed to.
The brain loves estrogen,
Right.
It causes neuronal sprouting and, all these different things. So it's not just, hot flashes and night sweats and all
and
of
again,
that stuff.
just to bring it back around, this is why I think what you were saying before is so important to appreciate, that the women who have symptoms are the ones who are going to go get this looked at, and hopefully they'll go to a doc who knows the actual literature or the state of the field and can help them. The ones who don't have symptoms may not ever go get a hormone test. and maybe silently experiencing higher risk for all of these other conditions.
Right.
That's going to put them in a poorer outcome later on in life.
And some docs don't test hormones. Like, oh, you're in menopause, let's just give you some estrogen.
A lot. Like, I wonder what the proportion is, but my guess is it's probably more than 50%.
And that's maybe okay, because you're still going to get some benefit by adding that estrogen. The question is, what do you want to see in the labs?
Oh, you mean they treat without measuring the hormones? Right. So that's a different question. Yeah.
You're in menopause. We know you're in menopause. Okay, you have a high FSH. Let's just give you estrogen. Why are we going to test it now? We're just giving you estrogen and you feel better.
And when people do this, is it what is in when you think of hormone replacement therapy, what is in there? What does that mean? Just generic, not I know you're
generic estrogen and progesterone.
Okay, so testosterone is not even considered, and by most.
Yes, by most. Well, the FDA doesn't think women need or should. I mean, there's no FDA, there's no FDA approved product for women, right?
Yeah, okay, I'm not even going to go there.
Right. Yeah. everything out there is for, doses for men. It's hard to adjust those doses to get kind of an accurate one. Some people try with some of the gels and get a little bit, but usually.
Doesn't that make you angry? Like, I'm just sitting here thinking about the women in my life that I care about, and I'm getting angry that this isn't.
It is. I don't, do I get angry about it? I mean, I don't know. I'm just like, there's more misogyny in, there's, no, I don't know if it's misogyny, but just women are overlooked. But there was a patch that went almost to the end, like a testosterone patch for women that got all the way close to being approved. And then at the very last minute, the FDA said, oh, there may be some concerns about heart issues or those things. So they didn't approve it. And I don't know if there's another company going to go through all of that again with all that money to try to get something approved.
Yeah, this is where the incentive structure and the cost of getting FDA approval really, I think, is detrimental, because you're right. Nobody's going to invest to try to get a product approved, especially when you can prescribe it off label at lower doses, right?
Yeah, we just have to compound it, and then we can get some kind of appropriate doses. But then there you are, because no insurance is going to pay for it then.
And how much is testosterone compounded for women? Ballpark,
depends on how you're doing it. So there's really 3 options that are. I mean, there might be others, but we don't really swallow it as a pill because it's hard on your liver. So a cream, pretty common, daily application. Sometimes we don't get the outcomes we want. Some people don't absorb it as well. We don't get the, but a lot of women are fine on cream, and you're probably averaging about $35 a month for a testosterone cream on average
in
from
the
a company
therapeutic
pharmacy.
range for women.
Yeah. And then there's injections. That's a subcutaneous weekly injection. Probably that's self. So you do that yourself. And if needles are a barrier, that's not a really good option.
Yeah.
Cost-wise, you're probably $60, $70 a month to do that, but you're getting it into your body, right? We don't have to question what we're getting in you versus, is it metabolizing through the skin or absorbing? So, and then there's subdermal pellets, which are placed by the physician in the subcutaneous fat, usually in the upper outer hip. That then you're not doing anything as the patient. You just get your dose, usually 3 times a year. So you're averaging about $100 a month to do that, because it's really the procedure you're coming in to have done. The pellet itself really doesn't cost much. It's just the procedure the doc has to do.
Yeah.
So that's kind of the cost.
So there are some options.
There's options, but I can send someone to a pharmacy to get their estrogen patch. Their insurance covers it, or whatever their copay is. But I can't send them to a pharmacy to get their testosterone, which could run through their insurance. All the compounded stuff is not going to, because it's not FDA approved, because there's not an FDA approved product, it can't run through insurance.
Yeah.
So they're having to pay out of pocket for that.
Yeah.
That hormone, which is pretty important hormone.
Right. So again, I just want to recap kind of high level for people, right? So, I mean, correct me if I misstate what you've said, but I think, hormone replacement therapy is the risks are far lower than what was, and I think still is, commonly perceived, and the benefits are far greater.
Absolutely.
And most women should at least have the conversation with their doctor
and decide,
about whether or not it's right for them.
Yep.
And not approach it from a perspective of fear, which I think is what most people have done because of what we've already talked about. So talk about it. And the key things to think about measuring here are estrogen, progesterone, testosterone,
FSH.
free and bound, and FSH.
FSH. Progesterone, I'm getting a little.
Oh, sorry.
I'm testing a little less. I'm testing it a little less because I'll just talk about progesterone and kind of just briefly. Progesterone is more of a math thing for the most part, meaning if we're giving it to offset the effect of the estrogen on the uterine lining, we're giving enough of a dose to do that. And you're getting some other benefits of progesterone, but you need at least enough to do that if you have a uterus, if you haven't had a hysterectomy.
Okay.
So for me, it's more of a math thing, not what the number is I'm getting in the lab. So, and then how much can they tolerate, right? And for some patients, we need a higher dose because maybe they're having some bleeding or something and they don't get as much effect out of that progesterone. So I don't really look at a lab value for that. I know it's low. They're not ovulating anymore. They're not going to make any progesterone. Right. So testing it, I'm a little less interested in per se.
Okay.
Estrogen, when I was talking about doctors not testing and just giving estrogen, there's two things. Because what is the dose you need for your symptom management? The dose is the dose, whatever that dose is.
Right. But as we've talked about, not everybody has symptoms who could benefit from the therapy.
So then when we look at labs, there's a few studies that show like your blood level of estrogen to get the most bone protection. So then I'm looking at that lab to say, are we getting those levels up so we're getting the most protection?
And do we need to worry about free and bound like we do with testosterone here?
No, I don't think there's any data that really shows a difference there. Yeah.
Okay.
So I'm looking at the labs to see, can we cover both things? So if they are symptomatic, okay, let's just say a symptomatic patient, we're going to do the dose that's, if they can, without side effects, that covers both the risk reduction if we're looking at labs and what they need for symptom management. If there's really not many symptoms, then we're really going to be looking at labs. Can we get that level up without side effects, if they do have side effects, to make sure we have peace of mind that we're getting the most protection?
Right.
So that's how I look at labs and how we dose.
Got it.
Yeah.
And then I think the other couple of take homes for me are, in women, mid-30s is about the time to start thinking about this. Do you need to be super proactive? I guess that's going to depend on your own personal sort of situation, but maybe at least start the conversation.
Start the conversation. See, is there anything we should be thinking about at this point? Are there some symptoms that we need to think about, managing as far as in that perimenopausal phase? Like I said, perimenopause for me is often more symptom management, not so much risk reduction at that point, because there's still enough hormone there that should be supporting bone and brain and all of those.
Yeah. But I mean, as you said, if women have been on birth control for a long time, maybe it makes sense to take a look at hormones and testosterone in particular.
Yeah, that one. And that's when, if I'm seeing someone where we are doing a BIA and then we are looking at muscle mass, we're looking at all those other things. And if we're having problems there, we would be looking
and what do you think about, there are, I think, many women who are under-muscled compared to optimal.
Yep.
And would you think that women who are in, say, their 30s, 40s, under-muscled and maybe have had challenges building or maintaining muscle, that testosterone would be a place to look?
Absolutely. Yes, we do that. And my colleague does a lot of weight management in our office, and he'll send those women to me if he's seeing, they're just, they're definitely sarcopenic, and usually we'll see it in the lower body for some of those women. And they're like, you got to do something. You got to do something for me. So I'm like, okay, let's work on that. Yeah. So absolutely, we'll see it. Yeah.
And one thought that just occurred to me in this context is with GLP-1 agonists. Do you see or do you monitor hormone levels? I would imagine that people on GLP-1 agonists, we know they tend to lose lean mass at the same time they lose muscle mass. Yeah. Do you see declines or dysregulation of hormones?
I haven't looked at that. I have not seen or really looked at that as far as a connection. So interesting thing to think about. I don't know.
Yeah. And I mean, Nick and I have tossed this idea around a couple of times, but would testosterone in particular therapy combined with GLP-1 agonists maybe offset some of the lean mass loss. It's total speculation, but combined obviously with resistance training too.
Likely. I mean, because what do we have? We need the ingredients for the muscle. We need the stimulus to the muscle, just like bone, right? The ingredients, the stimulus, and the hormone.
Right.
So, yeah, if you can optimize that hormone, and then you're going to be ahead of the game, right? Getting all those things in place.
Right. And I mean, the GLP-1 agonists are going to induce a caloric restriction state.
Right.
But if you can bring up the stimulus and the hormone, maybe you can at least maintain as opposed to losing half lean mass, half fat mass.
Yeah. Yeah. And we do prescribe GLP-1s in our practice, and we do prescribe a lot of testosterone in our practice. Right. So yeah, I think we're seeing that. I'm thinking one patient in particular, and I don't, in her whole adult life, she's not been able to obtain a weight loss that she's been able to with the GLP-1s. But we also have her on testosterone. We also have her seeing our nutritionist. We also have her at the gym, and having great success. But we do have that testosterone on board.
Yeah, and I think that these things all tie together in really important and complicated ways. And so if you can hit it from multiple angles, you have much better chance at success. So it makes perfect sense. Awesome. Well, this has been really fun. Yeah. Thank you so much. I learned a ton. I'm going to walk out of here just feeling like, wow, this day has been awesome because I've learned a lot. So
good. Oh, I'm glad.
So Kim, thanks so much. Where can people find you if they're interested in learning more and want to learn more about you?
So we're at the Institute of Complementary Medicine in Seattle, Washington. We're in the main Capitol Hill area where all the hospitals are. And we have our website is icmedicine.com. That's the letter I, the letter C, the word medicine.com.
And we will put that in the description in the show notes. Mm-hmm. Hope you guys enjoyed this conversation as well. As always, please feel free to leave a comment or question below. And if you're not yet a subscriber, hit that subscribe button. And I hope to see you next time on the podcast.